I want to give you a feel for what the Commission has been doing since it was launched. It was launched on February 28th, 2008, and I'll talk a little bit about the research, about the field hearings, about the special events, and really we are all building up. This is our last public event before we have a release of our report in early April. So the Commission was launched in February 28, 2008. It was launched in Washington, D.C. in Union Station. We announced the Commission. We released the first report, and I will give you some detail of some of the highlights from the first report in a minute. We launched the website of the Commission, and you may not have heard about it before. It's really important that you go to the Commission's website, commissiononhealth.org, commissiononhealth.org. It's a wonderful resource. I will illustrate in my talk soon some of the resources that exist there to even enhance your understanding of some of the health challenges as they take shape in the state of Tennessee. We've also been engaged in terms of the launch in Policymaker Outreach. We spent a lot of time, the staff of the Commission and some of the Robert Wood Johnson Foundation staff on the Hill meeting relevant legislators' offices to brief them about our existence. And since then, we've had other outreach activities to them. We've held congressional briefings, both at the launch and subsequently, so that we're keeping them up to date on what we are finding and what the data that is emerging that is important as a nation that we can move forward. One of the things we did at the launch was to dramatically illustrate some of the gaps in health that exist. And we used this tool, a subway map of Washington, D.C., and showed how health status varies depending on which train you take. You board the subway in the morning. And you can see gaps on the red line from 81.3 years in life expectancy to 72 years in life expectancy just along one line of the DC subway system. We have used that approach as we've gone to different areas to use. In North Carolina, we had a field hearing I'll talk about in a minute in the Raleigh-Durham area, and showed by along the freeways of North Carolina, you can see variations in health, and we've shown that by county in Colorado and by the train system in Philadelphia as well. Our report, which is available on the website, is entitled Overcoming Obstacles to Health. This was the initial report from the Foundation to the Commission that lays out the problem that the Commission was designed to address. I want to highlight a few findings from the report to give you a feel for the issues that the Commission is seeking to address. But want to remind you again, commissiononhealth.org, you can download the PDF of the report, as well as PowerPoint slides. That's all of the slides that I will show you from the report are available on the website, either in PDF form or in PowerPoint form. So you're doing a talk, you can just pull a PowerPoint from the website to enhance your talk. Okay, what were the main points of this report? One is that the United States is not realizing its health potential. And importantly, while there are gaps in health, and you will see this as a recurring theme, all Americans can do better in terms of health. All of us can take steps to improve our health. We need to take a fresh look because what we have been doing so far is not working. We need to look beyond medical care. We need to create more opportunities for everyone to be healthy. We want to look at the best ways to help people choose health, and this is an important moment to act. Those of you in the back probably cannot see this slide very well, but it shows how America is not getting good value on its healthcare dollars. Basically, if you look at the graph of where other nations are and how much they're investing in health, our health should be a lot better than it currently is in the United States. Not only is our health, we're not doing as well as we could, but the data also indicates that we are actually losing ground. You can't see these slides at the back, but basically it shows that on the area of infant mortality, if you compare where we rank today among the nations of the world, we have fallen from where we ranked in 1980. So over time, our relative standing is increasing. Now, in fairness, our absolute standing isn't worse. We are lowering infant mortality rates, so we are improving, but other countries are improving more rapidly than we are. they're doing something right that we are not doing, so that they are making more progress and our relative standing is getting worse. The same is true if you look at life expectancy. Compared to where we rank today, 25th in the world on life expectancy. Some other analyses show we may rank as high as 30th in the world on life expectancy. Cuba has higher life expectancy than the United States. It's stunning, with very small investments in medical care. And compared to where we ranked in 1980, again, we are losing ground. So it's really time for a call to action by the nation. This slide illustrates infant mortality differences by education level, and really makes the point that health falls short of what it could be, and that is evident even among the earliest marker of health, looking at the rate at which children die before their first birthday in the United States. Americans at every education level should be healthier. What is illustrated here, you probably can't see it clearly, but for both men and women, as education increases, life expectancy increases. The similar pattern is evident by income. As income increases for both men and women in the United States, life expectancy also increases. America's children at every income level should be healthier. We see large gaps in the health of children, the self-rated health of children, by education level as well and income level. Higher rates of chronic illness, again, dramatically distributed by income in the United States. So for virtually any indicator you look at of health, we see these dramatic variations in health by income and education. What we also, and this was new research, by the way, that Dr. Braverman and her team did in terms of preparing this report. And what is evident here is that the gaps in health by income exist within each racial group. So whether you look within the black population, the Hispanic population, or the white population, you see the similar pattern across all groups of dramatic variations in health by income. It's not generally recognized in the United States because a lot of the federal health statistics are reported regularly by racial and ethnic status. And so it's not generally recognized that the gaps in health within each race by income and education are larger than the racial gaps in health. Let me state it a different way. The gaps in health between poor whites and middle-class whites are bigger than the black-white gap in health. And the gaps in health between poor African Americans and middle-class African Americans are larger than the black-white gap in health. So we really have huge gaps by socioeconomic status, although this chart shows even within each racial, within each socioeconomic group, there still is a racial effect as well. So it's not either or, you really have to look at both of them in terms of trying to understand the patterns that we see. And then the report also talked about the dramatic gaps by geography that I talked about, this 20-year gap in health linked to where you live in the United States. And one of the things we showed in a series of charts in the report is that the clustering of poor health by geography is closely tied to the clustering of low education and high poverty by geography. Those things go hand in hand together. One of the really disturbing trends in the report, we showed data on where the U.S. ranks on child poverty. And we rank very high among the best, highest income countries in the world, in that we have a very high rate of child poverty. This is very important. There's a growing body of research that indicates that the foundations for good health are laid in early childhood. The experiences that individuals have in some research, even before birth, and clearly in early childhood, sets a child on a foundation that can lead to poor health. Dr. Jack Shonkoff, who was one of persons who spoke to us when we did a field hearing on early childhood, shows the extent to which exposure to what is called toxic stress in children actually alters brain architecture and alters their response to other stressors that puts them on a trajectory of poor health. Now, what is striking in this growing body of research looking at the impacts of early childhood on adult health, that it's not just the fact that those individuals have more mental health problems and more substance abuse problems in adulthood, but children exposed to toxic stress actually have higher rates of cardiovascular disease, of cancer, and of diabetes in their 50s and their 40s and 50s compared to those that weren't exposed to those early childhood adversities. So starting early and protecting our children is really an important issue. This slide emphasizes the point that it's not just the poor. The Commission is not just looking at the health of the poor. There are shortfalls throughout the population, and all of us can be doing better. Even the middle class can be doing a lot better than we are in terms of health, so that when it comes to health, everyone could be doing better. One of the things our first report did as well was addressed head-on some of the economic consequences and the economic costs of these gaps in health. We had two economists who had both served on the President's Council of Economic Advisors to do a calculation. We asked them a very simple question. What is it costing the U.S. economy, these gaps in health, these shortfalls in health? What is it costing the U.S. economy? And they answered the question by saying, if all Americans experience the level of health as the college educated in the United States, what would the savings be to the U.S. economy annually? Do you know what number they came up with? $1 trillion a year. $1 trillion a year are the potential gains possible if all Americans had a health experience of the college educated. So it is costly in terms of its impact. So the focus of the Commission is on non-medical pathways to improve health. We are looking at economic opportunities and resources. We're looking at living and working conditions and how they can combine with medical care and personal behavior to improve health. Let me give you a feel for what the Commission has actually been doing. Our field hearings, which we have been conducting to raise awareness levels, to listen and to learn, and to take the messages beyond Capitol Hill and to focus on promising solutions. We've had three major field hearings. The first one was in North Carolina on early childhood development, and again we were looking at what are the solutions, and we went to the Raleigh-Durham area in North Carolina because we knew that there are some creative programs there that are making a difference in terms of investments in early childhood. And these are just some pictures from our Raleigh-Durham field hearing. Then we went next to Philadelphia, where we focused on healthy homes and healthy communities. What can we do to improve health in our communities and neighborhoods? And we had a very good time there looking at what can be done both in terms of improving housing. One of the things that was probably most impressive to our commissioners was a visit that half of the commissioners paid to a ShopRite store in the Philadelphia area. The state of Pennsylvania has led the country in an innovative program that is a combination of public and private funding, mainly private, but it took a public funding to seed the process, that has been able to successfully put on the table 56 new full-service supermarkets in rural and urban Pennsylvania to improve access to fresh fruits and vegetables and a healthier diet. So it's really an example of an innovative program that we took a look at. And then we've also, our final field hearing in December was in Denver, Colorado, where we looked at the workplace and what were the opportunities of making workplaces healthy and what were the opportunities there to make a difference. And these are some highlights from our Denver field hearing. One of the things we've done is that with each field hearing, we also provide issue briefs that provide background material on the particular topic of the field hearing. All of the issue briefs are available on commissiononhealth.org. So for the North Carolina field hearing, there is an issue brief on early childhood. It's a brief summary of the research evidence on early childhood, as well as promising solutions in that area. For Philadelphia, we had two issue briefs, one on healthy homes, and one on healthy neighborhoods and communities. And for Denver, we had an issue brief on the work environment and what's possible in terms of making workplaces healthier places to live. Again, the website, some of the resources on the website, and I want to highlight two of the tools that we created that are available to you on the website. One is a state chart book on child health, and the other is an interactive tool we call the Education and Health Calculator tool. And so this is a shot from the website, the Education and Health Calculator tool. What it allows you to do is you can do this for every state in the union. You can go in and look at your state, and for your state you can look at what's the relationship between education and health in your state. So this is the example. I've just pulled a slide for the state of Tennessee. And you could see that in the state of Tennessee, the average level of education is 51% of the population is the percent of adults who have some college education or more. You can see how that compares to the US average. For the United States overall is 58%. You can also see what's the best state. The best state is the state of Washington with 67%. And then on the far side gives you the details for the state of Tennessee for the total deaths in a given year, for what the mortality rate is, and what is possible. It's an interactive tool, so you can move the slider along that axis, and you could see what if we change the level of education in Tennessee. How would the overall mortality rates change? And the final column actually gives you the number of deaths that would be averted, the number of lives that would be saved then in the state of Tennessee by changing the education dynamic. And I illustrated what you would find for this county, Washington County, Tennessee. The data is available at the state level. It's also available at the county level. Not for every county, and I know that it will not be available for many counties in Tennessee, given the last session, because we can only get stable estimates if there's a population of 100,000 or more. So for some counties that are small, with less than 100,000 or more population, we do not have stable estimates. But if the county has 100,000 or more, there is an estimate. So what you can see is where this county ranks. So the state of Tennessee average for education percent with some college education is 51%. Washington County is slightly higher than the state overall. Again, you can see the numbers before. But what you can see is if you moved the Washington County up to where the state of Washington is, the best rate in the county, you could see that you would avert 41 deaths per year. You would save 41 lives each year in this county alone. And you can do this at a state level, and you can do it for any other state, and you can do it for other counties in the country. It's a wonderful tool that policymakers can use, and you can use in some of your own work. That's the Education and Health Calculator tool on the website. What is also available on the website is a state-by-state chart book that we produced on child health. We plan to produce a similar one in the near future on adult health, but this is the child health report, and I want to show you just data from the state of Tennessee from the state-by-state chart book. But you can get similar data for every state in the union. Again, the PDF is online. You can download the PowerPoints for your state from the website. So here is there's data on infant mortality and on child health, over an overall summary measure of child health. What is important? There's several things important to this slide. So what is evident here is on your left is the infant death rates in the state of Tennessee by mother's education, and to the right are infant death rates in the state of Tennessee by racial and ethnic status. And what is evident overall, you can see the state of Tennessee, the overall infant death rate is 8.8 deaths per 1,000 live births, and that is higher than the national average, which is 6.5 deaths. And we also show a benchmark. The benchmark is 3.2 deaths. Where did the benchmark come from? The benchmark, we came up with the benchmark by looking at the highest education group, women with a college education or more, in the state that is doing the best. Okay? And I think in this case, it was New Jersey and Washington State. This is the important point. There is no biological reason why all Americans could not have the same experience. And so we use that as a national benchmark. And the first important take-home point is using that as a national benchmark, everyone, all of the major groups, every racial group, every education group, even college-educated women in the state of Tennessee, are falling behind the national benchmark, falling below the national benchmark. So that's my point, where we bringing home the point, all of us can do better in terms of health. But then, if everyone is doing badly, some folks are doing a whole lot more badly than others. The shortfalls are huge. You can see for African Americans, the shortfalls are very large for women who have not completed high school. But you can see the gradient, but you can also see a target that all Americans can reach, and the opportunity for all of us to make improvements in terms of health. There's similar data on child health indicators. In the interest of time, I didn't use the slide on child health. One of the interesting things we did with the child health indicator, we looked at those who were doing best at not only the highest education group, but the highest education group with good health behaviors. So we looked at households where no parent smokes and where at least one parent got a regular exercise, and they do better. Those persons with high education and good health behaviors do better than persons just with high education. So it shows that education, good health practices, makes an added contribution. But you can find that on the website, another resource. So our timeline, we've already completed our 3 field hearings. We've been on a very short, tight schedule, as you can see. We've also done special outreach in areas where we thought it was critical for us to get vital information. So we had an experts meeting in Washington, D.C., looking at federal food and nutrition policy. The federal government spends a lot of money on various food programs, whether it's the WIC program or the food stamps program or the school lunch program, and we're looking at opportunities there. And another special learning experience for the commission was coming here. We really wanted to see how many of these issues played out in rural areas, and we thank Senator Frist for pointing us in this direction and the importance of attending to this. But we are really moving towards the April 2 deadline of getting a report out with actionable recommendations, which one of the important things about the website I haven't mentioned is commissiononhealth.org. There is an opportunity to actually make recommendations, make suggestions to us. You can go onto the website and give us ideas. I would say right now, you need to do it quickly because we are in the process of writing recommendations, of drafting it, of getting feedback from our commissioners. So do get back to us quickly, but there is a way for you to get involved. So what are the main messages of the commission? America is not as healthy as it could be. There's more to health than healthcare, and where you live, learn, work, play, and worship matters. In fact, they have a bigger impact on affecting your health than going to the doctor. Now, don't get me wrong. We have Dr. Frist on the commission and other physicians on the commission. We believe in good medical care. But medical care as practice is largely the repair shop. It's where we go when we are sick. The focus of the commission is what can we do to help us not to become sick in the first place? How can we promote good health? So this is our mantra. There's more to health than healthcare. A lot of the focus in health policy now is around medical care and affordability and access and coverage, personal responsibility. All of these are important, but we believe it's also important to think of the living and working conditions in homes and communities and the social and economic resources and opportunities that all together come to shape the health that we have. So that gives you an overview of the Robert Wood Johnson Foundation Commission to Build a Healthy America. We think this is an opportune time. We are looking forward to your input. We are looking forward to what we will learn here that will help to shape and draft what we make recommendations for. And right now, we're looking forward to your comments and questions and input for us as we move on with the program. I would invite Senator Frist, Dr. Wilhelmine Miller, Dean Rosen to join me on the platform as we listen to questions and comments you might have for us. Thank you.